Assessment of the ear actually begins when you take the patient's history. Watch for nonverbal cues. Is the patient's voice unusually loud, soft? Do questions have to be repeated? Are certain words a problem? Is the position of the body or head altered to aid in hearing? If the answer to any of these questions is yes, it may be an important clue that the patient has a hearing problem, a clue that you must verify during your examination of the ear.
Peter, I understand you're a student here at Stony Brook.
Yes, I am.
What year are you in?
I'm a junior.
I see. Have you ever had an ear examination before, Peter?
Yes, I have.
How many years ago?
About 3 years ago.
Have you had any problems with your ears?
No, I haven't.
Any earaches?
Well, when I get a cold, I get an earache.
How does it feel when you have a cold?
It's like a sharp pain.
And do you get a little hard of hearing at that time? Or?
Yes, I do in that ear.
I see. Okay. Well, when I examine that ear, I'll try to be very, gentle with it in case it's sensitive.
The ear examination consists of 3 major parts: examination of the external ear, examination of the internal ear utilizing the otoscope, and testing of hearing acuity. When examining the external ear, note the size, shape, and position of the pinna, as well as the condition of the skin. Check the tragus for tenderness. Inspect the external meatus for size and for the presence of discharge, swelling, redness, or lesions. Also, check the preauricular and postauricular nodes.
Okay, I'm going to examine your ear now. First, I'll examine the position of the ear, and that looks fine. Now I'm going to feel for any lumps or nodules.
Okay.
When I wiggle your ear this way, does that bother you?
No, it doesn't.
How about here?
No.
Okay. Now I'm going to feel for the lymph nodes that are right in front of the ear. You tell me if they're sensitive at all, Peter.
Okay.
Now behind the ear. When I press on this mastoid bone, does that bother you at all?
No, it doesn't.
Okay. There's no discharge in the ear. Everything looks fine, Peter. I want to examine the other ear now.
Okay.
Again, the position is fine. I'm feeling again for any lumps or nodes. Discharge. So far, everything looks just fine, Peter. The next part of the examination, I'll be using the otoscope.
After the external ears are examined, the auditory canal and the tympanic membrane are inspected with an otoscope. When using the otoscope, be certain to select the largest size speculum that will fit comfortably into the patient's ear. Attach the insufflator tube firmly to the aperture in the head of the otoscope. Hold the otoscope as you would a pencil. When examining the ear, brace your hand against the patient's head so that you will still maintain good control of the otoscope if the patient should accidentally move his head. Tilt the patient's head slightly away from you and straighten the ear canal by pulling upward and backward on the auricle for the adult patient and down and back for the child. Then slowly and carefully insert the ear speculum into the canal no more than 1/2 to 3/4 of an inch for the adult and 1/4 of an inch for the child. The ear canal, especially the inner 2/3, is very sensitive to pressure, so try not to touch the sides of the canal with the tip of the speculum. As you insert the speculum, check the canal carefully for its color and for the presence of lesions, foreign bodies, discharge, or swelling. If too much cerumen is present, it may be necessary to remove it in order to fully visualize the ear canal and the tympanic membrane. The tympanic membrane appears as a thin, gray, partly transparent oval membrane. Note any differences in color that may indicate an inflammation, a fluid level behind the membrane, or a perforation. Prominent landmarks of the tympanic membrane include a triangular cone of light known as the light reflex on the lower anterior part of the eardrum, the lower end of the malleus known as the umbo at the inner tip of the cone of light, almost at the center of the eardrum, and the short process of the malleus, a tiny knob directly above the umbo. Extending upward and outward from the short process are the anterior and posterior malleolar folds, marking the borders of the pars flaccida and the pars tensa. After clearly identifying the major landmarks, gently squeeze the pneumatic bulb of the insufflator to cause movement of the tympanic membrane. Normally, the drum will move in and out gently in response to the change in air pressure. Compare the right eardrum with the left in terms of color, landmarks, and the presence of retractions, bulgings, or perforations.
I'm going to move it around. I'm going to give it a puff of air. Okay, Peter, everything looks good there.
Stand to the side of the patient, out of his line of vision, and place your mouth about 18 inches from his ear.
Could you occlude that?
Exhale, and then whisper a number from 1 to 10 in a low whisper. Exhaling gives you a better control over the intensity of your voice.
10. 10. 8. 8.
Okay, that was fine. Now the same thing with the other ear.
12. 12. 6. 6.
Okay, fine, Peter.
The Weber test is used to test bone conduction. Use a 500 to 1000 Hertz tuning fork. Tap it lightly so that it doesn't ring too loudly, and place the stem firmly against the middle of the skull or the forehead. Hold the tuning fork by the stem, being careful not to touch the tines.
Yes, because if you had a hearing loss, you would hear it more in one ear than the other. Okay, now I'm going to do another test, again with the tuning fork. I'm going to strike it on my knuckles, start the sound, and place it on this mastoid bone here. You tell me when the sound stops.
Okay.
Air conduction is normally greater than bone conduction. The René test is used to test this aspect of hearing by testing bone conduction on the mastoid bone and air conduction next to the pinna.
You hear it now?
Yes, I do.
Please tell me when it stops.
If the sound is not heard next to the ear or is heard for a shorter time by air than by bone conduction, the patient has a conductive loss.
Okay, I don't hear it anymore.
Okay, that's fine. Now I'm going to do the other ear, Peter.
I don't hear it anymore.
Hear it now?
Yes, I do.
Tell me when it stops.
I can't hear it anymore.
Good. The sound was conducted longer by doing it in the air conduction than it was on the bone conduction, so that's normal.
Oh, good.
This concludes the examination of the ear. The information obtained from the examination should be recorded as follows. Ears positioned bilaterally symmetrical. No lesions or masses of auricles or canal. No discharge. Moderate amount of dark cerumen, both ears. Tympanic membranes intact. Landmarks clearly identified. Auditory, can hear low whisper at 18 inches. Weber, equal bilaterally. René, air conduction greater than bone conduction. An accurate assessment of the ear is crucial since many ear problems can result in loss of hearing acuity if untreated. If any abnormalities are noted, referral to a specialist for a thorough examination is indicated.